Question 1. Radiation-induced toxicity. A 55-year-old patient with locally advanced head and neck cancer is undergoing definitive intensity-modulated radiotherapy IMA with concurrent cisplatin. After completing 30 fractions of radiation, the patient reports worsening dysphagia, odynophagia, and thick secretions. On examination, there is significant mucosal erythema and ulceration in the oropharyngeal region. What is the most likely cause of these symptoms? A. Bacterial superinfection of the oropharynx. B. Acute radiation mucositis. C. Oropharyngeal candidiasis due to immunosuppression. D. Chemotherapy-induced stomatitis. Answer: B. Acute radiation mucositis. Explanation: acute radiation mucositis is a common side effect of head and neck radiotherapy. It results from direct epithelial damage due to ionizing radiation, leading to erythema, ulceration, and pain. Radiation-induced mucositis typically occurs around the third week of treatment and peaks near the end of therapy. Incorrect answers. A. Bacterial superinfection is possible but less like the primary cause. Secondary infections can occur, but mucositis is the underlying radiation-induced injury. C. Oropharyngeal candidiasis is a frequent concern in immunosuppressed patients, but it presents with white plaques rather than ulceration and thick secretions. D. Chemotherapy-induced stomatitis is more generalized and not confined to the irradiated region. Mucositis caused by radiation is localized to the treatment field. Guidelines from the National Cancer Institute, NCI, and Radiation Therapy Oncology Group, RTOG, categorize acute mucositis using standardized toxicity grading, emphasizing hydration, pain management, and supportive care as key strategies for management. Question 2. Clinical trial design. A new checkpoint inhibitor for metastatic non-small cell lung cancer, CELSA, is undergoing clinical trials. The researchers plan to randomize 500 patients to receive either the investigational drug or standard of care chemotherapy with a primary endpoint of overall survival. The study is blinded, and neither the patients nor the investigators know which treatment each patient is receiving. What clinical trial design is being used? A. Phase I dose escalation study. B. Phasomon trial. C. Phasomon randomized controlled trial. D. Phasomon post-marketing surveillance study. Answer: C. Phasomon randomized controlled trial. Explanation: a Phasomon randomized controlled trial (RET) is designed to compare a new treatment against the current standard of care to determine efficacy and safety in a larger population. Features of this trial include randomization. Patients are assigned to treatment groups in an unbiased manner. Blinding. Both patients and investigators are unaware of group assignments. Bias. Primary endpoint of overall survival (OS). A key measure in oncology trials assessing treatment efficacy. Incorrect cancers. A. Phase I trials focus on dose escalation, safety, and pharmacokinetics, usually in a small number of patients. B. Phasomon trials evaluate efficacy in a single-arm or small randomized study but do not compare against standard treatment. D. Phasomon trials occur after regulatory approval to monitor long-term safety and effectiveness. According to the U.S. Food and Drug Administration (FDA) and European Medicines Agency (EMA) guidelines, Phasomon trials are the gold standard for regulatory approval before widespread clinical use. Question 3. Scenario-based question: oncological emergency. Superior vena cava syndrome. Mr. Rodriguez, 64-year-old smoker with history of chronic cough and weight loss, presents with progressive facial swelling, dyspnea, and distended neck veins. His symptoms have worsened over the past 2 weeks. Contrast-enhanced CT scan of the chest reveals large right upper lobe mass compressing the superior vena of SVC. What is the appropriate initial management? A. Immediate chemotherapy. B. Urgent radiotherapy. C. Insertion of SVC stent with anticoagulation. D. High-dose corticosteroids, followed by tissue biopsy. Answer: C. Insertion of EC-TET with anticoagulation. Explanation: superior vena cava syndrome (SVCS) is a medical emergency caused by compression of the SVC, often due to lung cancer or lymphoma. The immediate priority is relieving venous obstruction to restore circulation. SVC stenting with anticoagulation provides rapid symptom relief and is the first-line intervention in symptomatic patients with moderate to severe obstruction. Incorrect answers. A. Immediate chemotherapy is appropriate for chemosensitive tumors, e.g., small cell lung cancer, lymphoma, but it does not provide rapid relief in most cases. B. Urgent radiotherapy is beneficial for radiation-sensitive tumors, but takes several days to tumor burden and is not the fastest intervention. D. High-dose corticosteroids are used in lymphoma-associated SVCS, but biopsy should be performed after stabilizing the patient. The National Comprehensive Cancer Network (SEN) and American Society of Clinical Oncology (ASCO) guidelines recommend interventional radiology-guided stenting as the preferred emergency treatment for malignant SVCS with significant obstruction. Question 4. Radiobiology and fractionation principles. 60-year-old patient with early-stage non-small cell lung cancer also has been referred for curative intent radiotherapy. The oncology team is considering stereotactic ablative body radiotherapy (SABR) as the treatment approach. However, there is concern about the impact of fractionation on tumor control and normal tissue toxicity. Which of the following statements radiobiological principles in SABR is correct? A. SABR delivers radiation at higher dose per fraction, which reduces overall treatment duration but has no impact on tumor control probability. B. Hypofractionation in SABR exploits the concept of reoxygenation and repair, leading to better tumor control and lower normal tissue toxicity. C. SABR uses high biologically effective dose bed, which enhances tumor control but increases the risk of late radiation toxicity surrounding normal tissues. D. SABR is based on the principle of fractionation, similar to conventional radiotherapy, and does not significantly alter the tumor response to radiation. Answer C. SABR uses a high biologically effective dose bed, which enhances tumor control but increases the risk of late radiation toxicity in surrounding normal tissues. Explanation: SABR delivers high-dose radiation in a few fractions, leading to a higher biologically effective dose bed, which enhances tumor control due to the increased impact of radiation on DNA damage. However, high bed also means greater risk for radiation toxicity in normal tissues, particularly in organs with a lower tolerance to radiation. E.g., lung, spinal cord. Option A is incorrect because increasing the dose per fraction significantly impacts tumor control probability. SABR achieves a better therapeutic ratio by increasing bed while maintaining precise targeting to limit normal tissue damage. Option B is incorrect because while reoxygenation and repair are relevant to fractionated radiotherapy, hypofractionation, as in SABR, actually reduces the opportunity for reoxygenation and repair in tumor cells. Option D is incorrect because SABR is fundamentally different from conventional fractionation and is designed to maximize bed while minimizing normal tissue exposure. Relevant guidelines. Linear quadratic model (LQ model) helps determine the bed of different fractionation schedules. Radiotherapy Oncology Group (RTOG) protocols emphasize the importance of bed in optimizing tumor control and minimizing toxicity. American Society Radiation Oncology (ASTRO) guidelines support SABR for early-stage SLC, particularly in patients who are not surgical candidates. Question 5. Scenario-based question. Ethical dilemmas in oncology. Dr. Patel, an experienced radiation oncologist, is treating 45-year-old patient MS Nguyen, who has been diagnosed with STID Roman cervical cancer. After completing an extensive consultation about treatment options, including chemoradiotherapy, MS, Nguyen declines all oncologic treatment due to personal beliefs. She expresses her desire to pursue only alternative therapies despite understanding the prognosis and potential consequences. Dr. Patel is concerned about the implications of this decision and must determine the most ethical course of action. What is the best approach for Dr. in this situation? A. Persuade MS Nguyen to undergo treatment by emphasizing the severity of her prognosis and potential for disease progression. B. Respect MS Nguyen's autonomy, document her decision carefully, and offer supportive care while maintaining open communication. C. Seek court order to compel MS Nguyen to receive evidence-based oncologic treatment as it is in her best medical interest. D. Discharge MS Nguyen from the oncology clinic due to her refusal to comply with recommended treatment. Answer B. Respect MS Nguyen's autonomy, document her decision carefully, and offer supportive care while maintaining open communication. Explanation: patient autonomy is a fundamental principle in medical ethics. MS Nguyen has the right to refuse treatment as long as she has decision-making capacity. Option A is incorrect because coercion is not ethical. Physicians should provide balanced, evidence-based information without forcing decision. Option C is incorrect because court intervention is not warranted unless the patient lacks decision-making capacity or poses risk to others. Option D is incorrect because refusing to provide further care would violate ethical principles of beneficence and non-maleficence. Relevant guidelines: General Medical Council (GMC) and American Medical Association (AMA). Ethical standards affirm that patients with decision-making capacity can refuse treatment. Oncology guidelines emphasize the role of palliative care and shared decision-making in such cases. Question 6. Pharmacology. Chemotherapy-induced toxicities. 55-year-old patient undergoing chemotherapy for metastatic colorectal cancer develops progressive neuropathy after receiving multiple cycles of oxaliplatin. The patient reports persistent numbness and tingling in the hands and feet, affecting daily activities. Which of the following strategies is the most appropriate approach to managing oxaliplatin-induced peripheral neuropathy? A. Immediately discontinue oxaliplatin and switch to an alternative chemotherapy regimen. B. Reduce the oxaliplatin dose, extend the treatment interval. Or consider drug holiday to allow symptom resolution. C. Continue oxaliplatin at the same dose but add corticosteroids to help alleviate neuropathic symptoms. D. Increase oxaliplatin dosage to induce tumor response as neuropathy is tolerable side effect in metastatic settings. Answer: B. Reduce the oxaliplatin dose, extend the treatment interval, or consider a drug holiday to allow symptom resolution. Explanation: oxaliplatin-induced neuropathy is a dose-limiting toxicity that can be cumulative and potentially irreversible. The best strategy is to modify the dose or provide a treatment break to prevent progression of symptoms while maintaining efficacy. Option A is incorrect because immediate discontinuation may not be necessary if dose modifications can allow continued treatment with benefit. Option C is incorrect because corticosteroids are not effective in preventing or treating oxaliplatin-induced neuropathy. Option D is incorrect because increasing the dose despite worsening neuropathy is inappropriate and could lead to long-term disability. Relevant guidelines: National Comprehensive Cancer Network (SEN) guidelines recommend dose adjustments or treatment breaks in cases of chemotherapy-induced neuropathy. European Society for Medical Oncology (ESMO) guidelines emphasize that patient-reported symptoms should guide dose modifications. Question 7. Radiation therapy treatment planning. 65-year-old patient with locally advanced prostate cancer (TPMM) is scheduled to undergo intensity-modulated radiation therapy (IMiT) with concurrent androgen deprivation therapy (AP). The radiation oncologist must determine the appropriate dose distribution to balance tumor control and normal tissue toxicity. Which of the following is the most appropriate radiation dose? Fractionation scheme based on current guidelines: A. 45 Gi in 25 fractions to the prostate and seminal vesicles, with simultaneous integrated boost to 75.6 Gi in 42 fractions to the prostate. B. 70 Gi in 35 fractions to the entire pelvis, including the prostate, seminal vesicles, and regional lymph nodes. C. 60 Gi in 20 fractions to the prostate and seminal vesicles, with hyperfractionated approach. D. 50 25 fractions to the prostate and seminal vesicles, with simultaneous boost to 66 Di in 33 fractions to the prostate. Answer: A. 45 Gi in 25 fractions to the prostate and seminal vesicles, with a simultaneous integrated boost to 75.6 Gi in 42 fractions to the prostate. Explanation: dose escalation studies have shown that a total dose of 7.4-7.8 Gi improves biochemical disease-free survival in prostate cancer. Simultaneous integrated boost (SIB) allows for dose escalation to the prostate, reducing exposure to surrounding normal tissues. Option B is incorrect because elective nodal irradiation (INI) is not routinely recommended for localized disease without nodal involvement. Option C is incorrect because 60 Gi in 20 fractions is insufficient for definitive prostate cancer treatment without data supporting its long-term efficacy. Option D is incorrect because 50 Gi to the prostate and seminal vesicles is suboptimal for tumor control. Relevant guidelines: ASTRO and NCN guidelines support dose-escalated IMiT with or without hypofractionation. Question 8. Brachytherapy in gynecologic cancers. 50-year-old woman with stage A cervical cancer has completed external beam radiation therapy (EBA) to the pelvis, 45 Gi in 25 fractions, with weekly cisplatin chemotherapy. She is now scheduled for high-dose rate HDR brachytherapy Which of the following is the most appropriate brachytherapy dose prescription? A. 21 Gi in 3 fractions to point A. B. 28 Gi in 4 fractions to point A. C. 30 Gi in 5 fractions to point A. D. 40 Gi in 6 fractions to point A. Answer: B. 28 Gi in 4 fractions to point A. Explanation: the Embrace and Jekestra trials recommend a total dose of 8590 Gi EBIT plus brachytherapy for tumor control. Option A is incorrect because 21 Gi in 3 fractions would result in insufficient dose coverage. Option C is incorrect because 30 Gi in 5 fractions is below the optimal dose range. Option D is incorrect because 40 Gi in 6 fractions may increase toxicity risks. Relevant guidelines, ASTRO and ESTRO guidelines, support 4 fractions of 7 Gi each, total 28 Gi. Question 9. Toxicities of immunotherapy. 62-year-old man with metastatic non-small cell lung cancer SLCA is receiving pembrolizumab. After 4 cycles, he presents with severe diarrhea, abdominal pain, and weight loss. Which of the following is the most appropriate next step? A. Continue pembrolizumab and start loperamide for symptomatic relief. B. Hold pembrolizumab and start oral corticosteroids. C. Permanently discontinue pembrolizumab and initiate infliximab. D. Switch to an alternative immune checkpoint inhibitor. Answer: B. Hold pembrolizumab and start oral corticosteroids. Explanation: immune checkpoint inhibitors (ISIS) can cause immune-related adverse events (ARIEs) including colitis. Grade 2 or higher diarrhea warrants temporary discontinuation of the drug and initiation of corticosteroids. Prednisone MEAG. Option A is incorrect because continuing therapy without addressing colitis can lead to life-threatening complications. Option C is incorrect because infliximab is reserved for steroid-refractory colitis. Option D is incorrect because switching to another ISI does not resolve the toxicity issue. Relevant guidelines. ASCO and NCCN guidelines recommend steroids for grade 2 immune-related colitis. Question 10. Radiation-induced toxicity. 70-year-old man with prostate cancer treated with IMiD, 78 Gi in 39 fractions, presents 12 months later with new-onset hematuria and urinary urgency. Which of the following is the most likely diagnosis? A. Radiation cystitis. B. Bladder cancer. C. Urinary tract infection. D. Urethral stricture. Answer: A. Radiation cystitis. Explanation: chronic radiation cystitis occurs months to years after pelvic irradiation. Option B is incorrect because while bladder cancer risk is increased post-radiation, radiation cystitis is a more common cause of late hematuria. Option C is incorrect because UT is typically present with dysuria and fever. Option D is incorrect because strictures cause difficulty urinating rather than hematuria. Relevant guidelines or an ASTRO guidelines address management of late radiation cystitis. Question 11. Palliative radiation for bone metastases. 55-year-old woman with metastatic breast cancer presents with severe pain in the lumbar spine due to osseous metastasis. She is started on palliative radiation therapy. Which of the following fractionation schedules is most appropriate? A. 8 Gi in 1 fraction. B. 20 Gi in 5 fractions. C. 30 Gi in 10 fractions. D. Any of the above. Answer: D. Any of the above. Explanation: all 3 schedules are equally effective for pain relief per randomized trials. Single fraction 8 Gi is convenient but may have a higher retreatment rate. Relevant guidelines, ASTRO and NCCN guidelines, recommend any of these fractionation schedules for pain relief. Question 12. Whole brain radiation therapy for brain metastases. 58-year-old man with multiple brain metastases from non-small cell lung cancer SLCA is scheduled for whole brain radiation. A oncologist considers adding memantine to his treatment plan. Which of the following best describes the benefit of memantine over B? Reduces neurocognitive decline associated with B. Improves overall survival. Enhances the effectiveness of radiation. D. Decreases the risk of seizures. Answer: A. Reduces neurocognitive decline associated with B. Explanation: B improves intracranial disease control but increases the risk of neurocognitive impairment. Memantine, NMDA receptor antagonist, helps preserve cognitive function without compromising disease control. Option B is incorrect because memantine does not improve overall survival. Option C is incorrect because memantine does not enhance radiation effects. Option D is incorrect because seizures are not a primary concern by T patients. Relevant guidelines are TOG 0614 trial supports mementi T to reduce cognitive decline. Question 13. Hypofractionation in breast cancer. 47-year-old woman undergoes breast-conserving surgery, BCS, or TA invasive ductal carcinoma. The radiation oncologist considers hypofractionated whole breast irradiation, AB, instead of conventional fractionation. Which of the following best supports hypofractionated radiation? A. It improves overall survival compared to conventional fractionation. B. It is associated with higher rates of fibrosis and skin toxicity. C. It provides equivalent tumor control and cosmesis with short treatment duration. D. It is only recommended for older patients, 70 years. Answer: C. It provides equivalent tumor control and cosmesis with short treatment duration. Explanation 8b. G. 40 Gi in 15 fractions or 42.5 Gi in 16 fractions is non-inferior to conventional radiation, 50 Gi in 25 fractions. Option A is incorrect because ABR does not improve overall survival. Option B is incorrect because AB is comparable or low rates of toxicity. Option D is incorrect because it is recommended for all age groups, not just older patients. Relevant guidelines. ASTRO and NCN guidelines recommend ABR for most early stage breast cancer patients. Question 14. Stereotactic body radiation therapy SRT for lung cancer. 72-year-old man with stage I non-small cell lung cancer SLC is medically inoperable due to severe COP. The oncologist considers stereotactic body radiation therapy SRT. Which of the following best describes the role of SERT in early stage SLC? A. Provides equivalent survival outcomes to surgery in operable patients. B. Should only be used for centrally located tumors. C. Requires at least 8 weeks of recovery between treatment sessions. D. Is inferior to conventional fractionated radiation therapy. Answer: A. Provides equivalent survival outcomes to surgery in operable patients. Explanation SRTE. G. 54 Gi in 3 fractions or 50 Gi in 5 fractions achieves local control rates of 90%, similar to surgery. Option B is incorrect because central tumors require modified fractionation to avoid toxicity. Option C is incorrect because RT is delivered over 1-2 weeks with no long recovery period. Option D is incorrect because RT is superior to conventional radiation for early stage disease. Relevant guidelines SEN and ASTRO guidelines recommend SRT for medically inoperable early stage SESSI. Question 15. Radiation toxicity in head and neck cancer. 63-year-old man with locally advanced oropharyngeal cancer receives definitive chemoradiation 70 Gi in 35 fractions with concurrent cisplatin. 6 weeks after treatment, he develops persistent dysphagia and odonophagia. Which of the following is the most likely cause? A. Radiation-induced mucositis. B. Esophageal stricture. C. Osteoradionecrosis. D. Carotid blowout syndrome. Answer: B. Esophageal stricture. Explanation: chronic radiation effects include fibrosis and strictures leading to dysphagia. Option A is incorrect because mucositis resolves within weeks post-treatment. Option C is incorrect because osteoradionecrosis affects bone, not swallowing. Option D is incorrect because carotid blowout syndrome presents with acute bleeding. Relevant guidelines. ASTRO and ESCO guidelines recommend swallowing therapy to prevent strictures. Question 16. Proton therapy for pediatric tumors. 10-year-old boy is diagnosed with medulloblastoma and requires craniospinal irradiation (CSI). The oncologist considers proton therapy instead of photon-based radiation. What is the primary advantage of proton therapy in this case? A. Improves survival rates compared to photon therapy. B. Reduces radiation dose to healthy tissues, minimizing long-term side effects. C. Shortens treatment duration significantly. D. Increases the effectiveness of chemotherapy. Answer: B. Reduces radiation dose to healthy tissues, minimizing long-term side effects. Explanation: proton therapy delivers higher tumor dose while reducing exposure to the heart, lungs, and spine. Option A is incorrect because survival is similar between proton and photon therapy. Option C is incorrect because proton therapy does not significantly shorten treatment time. Option D is incorrect because it does not enhance chemotherapy effectiveness. Relevant guidelines. ASTRO and NCN guidelines recommend proton therapy for pediatric CNS tumors. Question 17. ART for oligometastatic disease. 55-year-old woman with oligometastatic colorectal cancer, single liver lesion, no extrahepatic disease, is referred for stereotactic body radiation therapy (SERT). Which of the following best supports the use of SRT in oligometastatic disease? A. Provides durable local control and potential survival benefit. B. Is ineffective compared to chemotherapy alone. C. Should only be used if there are 5 metastases. D. Is only palliative and not curative. Answer. A. Provides durable local control and potential survival benefit. Explanation. SRT for oligometastatic disease improves local control and progression-free survival. Option B is incorrect because SRT is effective in well-selected patients. Option C is incorrect because 5 metastases is the common criterion for oligometastatic disease. Option D is incorrect because SRT can be curative in select cases. Relevant guidelines. SEN guidelines support SRT for oligometastatic colorectal and lung cancer. Question 18. Postmastectomy radiation therapy (PRT) in breast cancer. 52-year-old woman with EN invasive ductal carcinoma of the left breast undergoes modified radical mastectomy with clear margins. The tumor is HER-positive, HER-negative, and she will receive adjuvant endocrine therapy. The radiation oncologist is considering postmastectomy radiation therapy (PRT). Which of the following best describes the rationale? PRT in this patient. A. PRT significantly improves local control and overall survival in no-positive disease. B. PRT is unnecessary because she had mastectomy with clear margins. C. PRT is only indicated for tumors or for positive nodes. D. PRT should be avoided in ER-positive patients receiving endocrine therapy. Answer. A. ERT significantly improves local control and overall survival in no-positive disease. Explanation. ERT reduces local regional recurrence and improves survival in patients with TN disease, tumor 2 cm with 1-3 positive nodes. Option B is incorrect because PRT is still beneficial despite clear margins. Option C is incorrect because 1-3 positive nodes is an indication for PRT. Option D is incorrect because endocrine therapy does not replace the need for PRT. Relevant guidelines. ASRA and SEN guidelines recommend ERT for node-positive breast cancer. Question 19. Brainstem dose constraints in SRS. 67-year-old man with 2.5 cm metastatic brainstem lesion from melanoma is scheduled for stereotactic radiosurgery (SRS). The team discusses dose constraints to minimize toxicity. Which of the following is the most appropriate brainstem dose constraint (SRS)? A. Max dose 12 Gy to avoid radiation necrosis. B. Max dose 15 Gy to balance tumor control and toxicity. C. Max dose 20 Gy because the brainstem is radioresistant. D. No dose constraint needed because SRS avoids normal tissue. Answer. A. Max dose 12 Gy to avoid radiation necrosis. The explanation. SRS delivers high-dose radiation precisely, but the brainstem is highly radiosensitive. Option B is incorrect because exceeding 12 Gy significantly increases the necrosis risk. Option C is incorrect because the brainstem is not radioresistant. Option D is incorrect because dose constraints are critical in SRS. Relevant guidelines. ARTOG and ASTRO guidelines recommend max dose 12 Gy for the brainstem SRS. Question 20. Acute versus late radiation toxicity. 65-year-old woman with stidome cervical cancer receives definitive chemoradiation EBRT plus brachytherapy. 4 weeks into treatment, she develops severe diarrhea and tenesmus. Which of the following best describes her condition? A. Acute radiation proctitis from rectal mucosal injury. B. Chronic radiation proctitis leading to fibrosis and telangiectasia. C. Radiation enteritis, which typically occurs years after treatment. D. Pelvic insufficiency fractures, late complication of radiation. Answer. A. Acute radiation proctitis from rectal mucosal injury. Explanation. Acute radiation proctitis occurs during or shortly after radiation and is reversible. Option B is incorrect because chronic proctitis develops months to years later. Option C is incorrect because enteritis is usually a late effect. Option D is incorrect because pelvic fractures occur years later. Relevant guidelines. ASTRO guidelines emphasize supportive care for acute radiation proctitis. Question 21. Proton versus photon therapy for esophageal cancer. 60-year-old man with locally advanced esophageal cancer (TNM) is referred for definitive chemoradiation. The oncologist considers proton therapy instead of photon therapy, weighs the primary advantage of proton therapy in this setting. A. Reduces radiation dose to the heart and lungs, lowering toxicity. B. Improves survival compared to photon-based radiation. C. Shortens treatment time compared to IMET. D. Increases radiation dose to the tumor, enhancing tumor control. Answer: A. Reduces radiation dose to the heart and lungs, lowering toxicity. Explanation: proton therapy delivers less radiation to normal tissues, reducing cardiac and pulmonary toxicity. Option B is incorrect because survival is similar between protons and photons. Option C is incorrect because proton therapy does not significantly shorten treatment time. Option D is incorrect because proton therapy does not inherently increase tumor dose. Relevant guidelines SEN and ASTRO guidelines recommend proton therapy for esophageal cancer. Question 22. SRT for liver metastasis. 58-year-old man with colorectal cancer and single 3 cm liver metastases is considered for stereotactic body radiation therapy SRT. Which of the following best supports SRT in liver metastasis? A. Provides high local control rate, 90%, with minimal toxicity. B. Is inferior to surgical resection in terms of survival. C. Should only be used for lesions 5 cm. D. Is primarily palliative with no curative potential. Answer: A. Provides high local control rate, 90%, with minimal toxicity. Explanation: SRT is highly effective for small liver metastases 5 cm require altered dosing. Option D is incorrect because SRT can be curative in oligometastatic cases. Relevant guidelines SEN and ASTRO support SRT for oligometastatic liver disease. Question 23. Spinal cord dose constraints in radiation therapy. 67-year-old man with TNM lung cancer undergoes definitive radiation 60 GI in 30 fractions. The radiation oncologist is concerned about spinal cord toxicity. Which of the following is the most appropriate spinal cord dose constraint? A. Max dose 45 GI to avoid myelopathy. B. Max dose 50 GI to balance tumor control and spinal cord toxicity. C. Max dose 60 GI because the spinal cord is highly resistant. D. No dose constraints needed for standard fractionation. Answer: A. Max dose 45 GI to avoid myelopathy. Explanation: radiation-induced myelopathy risk increases above 45 GI. Option B is incorrect because 50 GI exceeds the safe threshold. Option C is incorrect because the spinal cord is radiosensitive. Option D is incorrect because dose constraints are critical. Relevant guidelines: Quantec recommends max spinal cord dose 45 GI in standard fractionation. Question 24. Reirradiation considerations for head and neck cancer. 62-year-old man with history of AEC-negative oropharyngeal squamous cell carcinoma was treated 5 years ago with definitive chemoradiation 70 GI in 35 fractions with concurrent cisplatin. He now presents with local recurrence and is being evaluated for reirradiation. What is the most critical factor in determining the feasibility of reirradiation? A. Cumulative dose to critical structures such as the spinal cord and brainstem. B. HPV status of the recurrent tumor. C. Time interval since initial radiation is irrelevant in reirradiation. D. Presence of distant metastasis, which does not affect local treatment decisions. Answer: A. Cumulative dose to critical structures such as the spinal cord and brainstem. Explanation: reirradiation poses significant toxicity risks, particularly to dose-limiting structures. Option B is incorrect because HEV status affects prognosis but not feasibility of reirradiation. Option C is incorrect because a longer interval, 2 years, improves tolerance. Option D is incorrect because distant metastases would typically shift the focus to palliative care. Relevant guidelines: ASTRO guidelines recommend reirradiation only if benefits outweigh toxicity risks. Question 25. Cardiac toxicity in left-sided breast cancer radiation. 55-year-old woman with left-sided breast cancer (TNM) undergoes breast-conserving surgery followed by adjuvant radiation, whole breast radiation with nodal coverage. Which of the following is the best strategy to reduce cardiac radiation dose? A. Deep inspiration breath, hold DIB to move the heart away from the chest wall. B. Prone positioning, which reduces dose in all cases. C. Increasing the prescribed dose to reduce fractionation toxicity. D. Adding chemotherapy to minimize radiation dose. Answer: A. Deep inspiration, breath, hold, DIB, to move the heart away from the chest wall. Explanation: DIB reduces mean heart dose by increasing lung volume, pushing the heart away. Option B is incorrect because prone positioning is beneficial only for large-breasted patients. Option C is incorrect because increasing dose increases toxicity. Option D is incorrect because chemotherapy does not reduce radiation dose to the heart. Relevant guidelines: ASTRO and SEN recommend DIB for left-sided breast cancer radiation. Question 26. SRT for early-stage SLC. An 80-year-old man with severe COPD is diagnosed with EBMM on small cell lung cancer SLC, but is not candidate for surgery. Which of the following best describes the role of stereotactic body radiation therapy SRT in this setting? A. ORT achieves high local control, 90%, with minimal toxicity, but SRT is contraindicated in patients with poor lung function. C. SRT is inferior to conventionally fractionated radiation. D. SRT requires concurrent chemotherapy for best outcomes. Answer: A. ORT achieves high local control, 90%, with minimal toxicity. Explanation: SRT is the standard of care for inoperable early-stage SLC, offering excellent tumor control. Option B is incorrect because SRT is safe in patients with poor lung function. Option C is incorrect because SRT is superior to conventional fractionation for early-stage SLC. Option D is incorrect because chemotherapy is not needed for TERN disease. Relevant guidelines: SEN guidelines recommend SRT for inoperable early-stage SLE. Question 27. Whole brain radiation versus SRS for brain metastases. 58-year-old woman with HER-positive breast cancer and 4 brain metastases, each 2 centimeters in size, is being considered for radiation therapy. Which of the following best describes the advantages of stereotactic radiosurgery SRS over whole brain radiation SRS preserves cognitive function while maintaining control? B. SRS is only effective for single brain metastases. C. SRS is less effective but for multiple metastases. D. SRS requires whole brain radiation for optimal tumor control. Correct answer: A. SRS reserves cognitive function while maintaining local control. Explanation: SRS provides excellent local control while reducing neurocognitive decline. Option B is incorrect because SRS is effective for up to 10 metastases. Option C is incorrect because SRS can be equally effective for population. D is incorrect because T is now always needed for patients with limited brain metastases. Relevant guidelines: ASTRO recommends SRS for patients with 4 brain metastases to preserve cognitive function. Question 28. Rectal cancer radiation considerations. 64-year-old man with CTN rectal cancer is scheduled for neoadjuvant chemoradiation before surgery. What is the primary benefit of neoadjuvant radiation therapy in this setting? A. Improves local control and reduces the need for permanent colostomy. B. Increases the risk of postoperative complications. C. Radiation should only be given postoperatively. D. Neoadjuvant therapy does not impact survival. Answer: A. Improves local control and reduces the need for permanent colostomy. Explanation: Neoadjuvant chemoradiation improves local control and increases sphincter preservation. Option B is incorrect because radiation does not significantly increase surgical complications. Option C is incorrect because postoperative radiation is less effective than preoperative radiation. Option D is incorrect because neoadjuvant therapy improves survival in select cases. Relevant guidelines: SEN and ASTRO recommend neoadjuvant chemoradiation for stage-1 rectal cancer. Question 29. Dose constraints for the optic nerve in SRS. 55-year-old woman with 3 cm benign meningioma adjacent to the optic nerve is treated with stereotactic radiosurgery SRS. What is the maximum recommended optic nerve dose to minimize toxicity? A. Max dose 8 GI to prevent optic neuropathy. B. Max dose 12 GI to balance tumor control and toxicity. C. Max dose 20 GI because the optic nerve is resistant to radiation. D. No dose constraints are needed for benign tumors. Answer: A. Max dose 8 GI to prevent optic neuropathy. Explanation: The optic nerve is highly radiosensitive, and exceeding 8 Gi increases the risk of optic neuropathy. Option B is incorrect because 12 Gi is too high for the optic nerve. Option C is incorrect because the optic nerve is not radioresistant. Option D is incorrect because dose constraints are always necessary in critical structures. Relevant guidelines. Quantec recommends max optic nerve dose 8 Gi in single fraction SRS. Question 30. Radiation dose constraints for the spinal cord in SRT. 67-year-old man with T vertebral metastases from renal cell carcinoma is being treated with stereotactic body radiation therapy SRT. What is the recommended maximum spinal cord dose for single fraction SRT treatment to minimize the risk of radiation myelopathy? A. Max cord dose 10 Gi. B. Max cord dose 14 Gi. C. Max cord dose 20 Gi. D. No dose constraint is needed for the spinal cord necessita. Answer: A. Max cord dose 10 Gi. Explanation: radiation myelopathy is serious complication of SRT, and exceeding dose limits increases risk. Option B is incorrect because 14 Gi is too high for single fraction. Option C is incorrect because 20 Gi would cause significant spinal cord toxicity. Option D is incorrect because strict dose constraints are required to prevent myelopathy. Relevant guidelines. Quantec recommends max cord dose 10 Gi for single fraction SRT and 17 Gi for 3 fraction HOT.